Hello again. Welcome to Surgical Pathology Digital Slide Review and Sign Out. I'm Dr. Louis Hassel. Our session today is courtesy of the Digital Anatomic Pathology Academy, which is a joint venture with the Digital Pathology Association and Path Presenter. Perhaps symbolic, you'll notice that the image is a little bit out of focus today, and I'm hoping that today's case will help to bring into focus a challenging area of ovarian pathology. This case is a 60-year-old woman with a pelvic mass, slightly complex on histology, and no other apparent symptoms. This is an unusual presentation for this lesion, as you'll soon discover. So here we see this multiloculated, cystic and solid mass occupying the bulk of the ovarian parenchyma. We can see that it has blue areas and not a whole lot of necrosis. We've preserved some older ovarian corpora albicantia at the periphery. As we look at this tumor, we see at intermediate power here that it has sort of an alternating purple and chartreuse hue to it in differing degrees with an alternation back and forth between those kinds of areas. We see that also here in this larger area of solid tumor. And to a degree, we see it over here in the lining of many of the cystic spaces as well. So let's take a look and see what makes up these two components of the tumor. And we can see here that these darker, more amphiphilic cells are small and round, occasionally with slightly foamy cytoplasm, fairly uniform nuclei. And then these intervening cells have more eosinophilic granular cytoplasm. Here you can see very nice round nuclei to most of those cells. And we see that there's some intervening vasculature. We don't see a lot of nuclear pleomorphism or atypia, but we see this alternating pattern between sort of a tubular lamellar pattern and this interstitial pattern of cells. We see the solid and cystic component. Here we can see a little bit more of this interstitial component, and you can see again that it has this nicely granular cytoplasm with very uniform round nuclei. At this stage, we're thinking that these are some sort of steroid-secreting cell, some sort of an endocrine type cell. They certainly have that appearance. And we think these other tumor cells, such as we see here, have a more epithelial type of appearance, appearing in cords, nests, and strands. And then we have these cystic structures. Now, we do want to look and see if we have anything lining these cystic structures. Is there any heterologous elements, any mucinous elements, or anything like that? But we don't see that in this particular case. Here again, we see both components can be present. And we could look for quite a length of time to see if we actually have crystalloids of Reinke in these endocrine cells. And with maybe some good luck and a little bit of imagination, we would probably find one or two cells that may have some crystalloid type structure. Falling short of that, we might go the immunohistochemical route to see what sort of staining reactions we got with these two cell types. This, though, is a nice example of a biphenotypic tumor occurring in the sex cord stromal category that we have come to love as the Sertoli Leydig cell tumor. These tumors are composed of these two elements in variable proportions. And to make things more interesting, they have variable differentiation. The one that we've just looked at is quite well differentiated. The Leydig cells are particularly easy to recognize. The Sertoli elements are relatively well developed and show nice tubular formation. To make things more interesting in these tumors, and certainly provide fodder for numerous publications over the years, heterologous elements may be seen. And those heterologous elements can include muscle elements. They can include mucinous elements, so epithelial teratoma-like elements, or stromal elements, even cartilage and occasionally bone. Of late, it's been noted that these tumors have a Dicer1 mutation that may be present as a germline mutation or may be present as a sporadic tumor-related mutation. And that the differentiation and staging of these tumors is generally predictive of outcome. It's been said that the well-differentiated tumors, such as the one that we just looked at, have an extraordinarily good prognosis and essentially are benign. And that may be why in this particular patient, the presentation was not discovered until she was in her 6th decade. Because usually these are tumors that present earlier in life, particularly if they are associated with hormonal manifestations, which are most typically, as might be expected from the Leydig cell component, androgenic, meaning that they will produce hirsutism, ambiguous genitalia. They may produce amenorrhea or menstrual difficulties as the primary presentation symptoms. There are a couple of particular histologic types that are worth being aware of, and one is the Retiform subtype. So here's another tumor, this one presenting at a more typical age in a 20-year-old with some menstrual abnormalities. As you can see, it has a lobulated, solid appearance, a few follicular cystic areas, and some preserved ovarian parenchyma at the periphery. And while it doesn't look particularly remarkable at this power, there are areas which very nicely begin to recapitulate the reedy ovary. And I'll call your attention to this particular area here. And just come down onto this and see if this doesn't remind you of what the reedy ovary looks like. Yes, indeed, this is single low cuboidal cells lining a loose fibrovascular stroma with a delicate architecture. So how is that a Sertoli Leydig cell tumor? Well, as you can see here in other areas, we have these nicely developed tubules, which are quite mitotically active. And so these tubules and cords of cells would fit nicely for Sertoli cells. And then the question becomes, well, where are the Leydig cells? And as is often the case, they can be quite focal, particularly as you get into tumors that are less well differentiated. And so extensive hunt may be warranted. Immunohistochemical stains may be necessary to help to document the presence of those Leydig cells. Here again, we see more of this Retiform pattern juxtaposed between sort of a tubular form over here and the more trabecular or winding cords of cells over on this particular area over here. And again, Leydig cells are very difficult to find in this particular neoplasm. Areas along the periphery are an important area to search for them because they can sometimes be hiding in that kind of a location. Other areas where they may be seen are these more mesenchymal areas, such as seen here, where you may just find an occasional cell with a slightly more eosinophilic cytoplasm and a suggestion of a crystalloid of Reinke. The other features that can be seen, as I've mentioned, are heterologous elements that include myogenic differentiation. And this tumor did have some areas of myogenic differentiation. I think we can see maybe a little bit of it here. No, I'm not seeing it here. There are occasional areas where you may find strap cells. Here's a nice area to focus on. Here's an area where we see this trabecular pattern, a little bit of a tubular pattern, and this intervening stromal pattern. And again, you can see the atypia. You can begin to see some of these cells that look a little bit more like Leydig cells. But again, not well differentiated. And so these are the difficult cases when they're not well differentiated Leydig or Sertoli cells. That makes the diagnosis all that more difficult. So a couple of lessons from this then. Leydig cells can be very difficult to find in some cases. Retiform manifestations can be subtle, presenting only focally. But they're important to identify since, especially since some of the early findings on this tumor found that the retiform subtype did have a more adverse prognosis. And again, you can see sort of the immature mesenchymal elements here that might be worth consideration for heterologous element development. Now, of course, the ovary is not the only location where these tumors can occur. And here's a nice section of testis with an area of tumor, again, having this mixed solid, variably cystic, sclerotic pattern that you can see here. We don't see the retiform pattern, but we see these nests and cords of cells here with quite a bit of quite clear cytoplasm, much more closely mimicking the Sertoli cells that line the seminiferous tubules. And these, particularly in a male patient, look very similar. Now, of course, Sertoli-only cell tumors can exist as well, both in the ovary and in the testis. And so search to exclude the possibility of Leydig cells is apropos. The behavioral differences are not dramatic, however. So here again, you get a feel for the different patterns that these Sertoli cell tumors can manifest. And it's particularly, I think, useful here to see as these cords of cells develop, very often the nuclei run kind of perpendicular to the pattern of the cord. That's very characteristic of Sertoli lesions, not usually seen in other trabecular pattern tumors like carcinoid tumors or neuroendocrine tumors. We'll go on and take a look at what some of these things can look like grossly. As you can imagine, with the variable histologic changes, the gross morphology likewise can be quite variable, ranging from, as you see here, quite solid yellow lobulated tissue to quite cystic and almost gelatinous appearing with relatively little intervening stromal tissue. The retiform tumors sometimes have been described as having a grape-like or a sort of fish egg-like appearance in some images. Now, immunohistochemistry can be quite useful in these tumors. Of course, they'll usually be positive with the normal sex cord markers such as inhibin, calretinin, and so forth. WT1, and also they will usually stain with vimentin and pancytokeratin. So that can be useful. Particularly these would be the Sertoli elements. The Leydig cell component, however, may be negative with many of these markers, but can stain with Melena and MART1. And so that can be a useful differential and a useful tool in the hunt for rare Leydig cell components. The heterologous elements can be, as I've mentioned, the intestinal mucinous type, which would, of course, stain with intestinal type markers. And if you have hepatoid elements, an even more rare variant, those may mark with AFP or maybe with glypican 3. So our final sign-out diagnosis today, even though this patient is elderly, this is a Sertoli Leydig cell tumor of the ovary. It's well differentiated, and she should do very well in follow-up of this lesion. So I hope that's brought our image a little bit more closely into focus. Thanks for joining me today. And please subscribe. We intend to post more of these, and we want you to not miss any of the material that we have to share. And feel free to share it with friends or colleagues, and add your comments below. Or you can just comment S below. Thanks very much, and we will see you next time.